week how the negotiated reimbursement with commercial payers is on a multi-year contract, while the budget is changing year to year. So I do understand that. So that's helpful. I still want to think about the rest of your math, but that's very helpful. Thank you.
You're welcome.
Yeah, so on the Medicare part, does Medicare change their reimbursement to Madam Ascutney based on our budget decisions?
No, Medicare doesn't give a rat's fanny. They just pay us what they pay us after audit of our cost report and our legitimate expenses and our annual audited financials.
Right. So, sorry, and I guess I'm still missing how it goes down 53%.
Because they don't pay us, they only pay us cost. That 47% is the percent of charge that they typically pay based on our historical run rate, and we use that run rate to predict the future. So Sarah talked about earlier that if you look at us historically, our expenses and our net revenue run pretty tight. And as long as we stay tight with that, then this number becomes applicable to the future.
Right. I get it. Okay.
If I decided that we were going to pull off a 5% margin next year, then there would be a break with net patient revenue and expenses, and I wouldn't be able to use that predictor for Medicare reimbursement because our expenses would not be growing in line with net reimbursement.
And Medicare pays by way of interim payments for outpatient and per diems for inpatient, and then get settled at the end of the fiscal year. And an ideal cost report settlement is close to zero. So, we like to maintain a very solid interim payment rate.
All right. Any other board questions?
Just one more on this same thing. So the calculations that you shared with us on this slide, but you use those to monitor your expense growth and keep your expense growth tight to your expected revenue. Is that correct?
No, we relate them and we compare them, but they don't drive them. So if I were to answer how do we budget, I ask my people three things. One, how busy are you going to be in your department next year? How many people do you need to perform that level of volume, which we test against historical productivity? And how much stuff do you need? Paper clips, bandages, whatever. And then we run that data through, and then we look at what amount of price increase do we need to cover that expense growth. And we do that based on our historical reimbursement rates from all payers. So they're done in concert, but they don't, expenses drive the bus more, but net revenue growth, sometimes we have to go back and keep revisiting the expenses until we can line those two things up and decide what we can live without and what we need to have.
Thank you.
Okay, I'll turn to the healthcare advocate.
Hi, thank you, Chair Foster. This is Charles Becker from the Healthcare Advocate's Office. Just have a quick question about your pharmacy charges. On page 4 of your narrative, you said our pharmacy prices are based on acquisition cost, so no price increases are applied to pharmaceuticals. And that stood out to me in a really good way. And I was going to ask you today if that actually meant your pharmacy costs are flat. But then on one of your slides today, you said pharmacy is up 2 to 8%, with the highest cost meds up greater than 4%. So I'm just trying to reconcile those two statements, if you could speak to that.
Yeah, fair. So this is one of those examples. where two things can be true. So when I got here, we had a multiplier for drug costs $100. We do a multiplier, and it's this, and so it's high, and it's distasteful. And so literally for 10 years, we have never increased our pharmacy markup to cover now. I mean, every year it's zero. Literally every year I've been here, it's zero. Now, if there's that product gets replaced with a new and improved product that costs more, which is usually what happens, right? We use the same markup. We don't change it. We don't take last year's $500 med and make it $505 this year. None of that happens. That said, in the inflationary question that you referenced secondarily, so yeah, depending on the drug that we're talking about, so infusion drugs, whether chemotherapy or medical infusion, those are all on the higher end of the inflation spectrum if you were to go back and look at the trade journals, and the others not so much. So if their pricing changes, that's our acquisition cost, but we never change the markup. It stays relatively flat. And what happens is things become generic or not the bleeding edge, right? Then there's actually a regression in price. And on top of that, we go after the 340B mixed use discount, which is roughly 20%. Does that help, or does that make it more murky?
No, it helps actually. And one of these days I'm going to figure out pharmacy pricing, but probably not today. But I appreciate your response. Thank you.
Thank you.
And I'll open up.
And we have no further questions. I'm sorry. Yeah.
No, that's great. Any public comment? Mr. Davis.
Thank you, Mr. Chairman. I've sort of made this comment before, but today's activities and the activities of the budget discussion so far have just made it seem even more important. And that is that we just have a huge aura of unreality here. It's particularly difficult, of course, in the valley, which is just a tangle. And it's going to be hugely difficult to make any real sense out of, because Dartmouth, okay, is so huge, and Dartmouth should be doing has to do all of the tertiary care, and tertiary care is where all the money comes from. So the small hospitals, especially in Vermont, but they have small hospitals everywhere, have a terrible time making enough money doing the stuff they have to do. So they try and make up the revenue deficit by doing as much heavy stuff as they can manage. This is all actual. There's a huge amount of data to show this. But this board has not looked at it at all. They have not looked at stuff like the leapfrog tests for surgical volumes. They have not looked at the problems, the quality problems of the Vermont system as shown by the PQI and PAU data. They have not looked at cost per capita in the service area, which is the real way we pay for healthcare. We pay for healthcare on a per capita basis, not on an individual basis. And nobody has said anything about all the consultant work that shows that Vermont needs 154 at least 154 fewer beds. That would account for 6 whole critical access hospitals. The problem about this, of course, is that it's so painful. I mean, it's politically painful, but that is the reality. And until because we don't need 14 hospitals, we need maybe 4, and maybe less than 4. Okay, and the ultimate, I think, of it, the first really, it's interesting. The first thing I've ever heard that started to get at this area was Member Holmes today wanting to know from Dartmouth, well, are you going to get enough volume to make your service areas lines look reasonable? If you find out from Dartmouth, will you tell us? Well, What you have is you have a pile up to the ceiling of data in your archives that tell you exactly the answer to those questions. Okay, and the problem is not that the data isn't there, but that the political will isn't there. Thank you.
Any other public comments? Okay, I'll turn it back to the Mount Ascutney team for any closing remarks you have.
I appreciate your time, and it's always fun to see you guys every year. I look forward to this, and then I look forward to my post Green Mountain Care Board vacation. I think the one thing that really I think we should think about, and there's nothing to determine here today, is our volume is not because we're marketing. Our volume is our volume. It's because we have community-based services that we're providing at a high level of quality with a high degree of patient satisfaction. We don't have an orthopedic subspecialty. We're not doing plastics here. We're just providing good quality community-based care. And I think our rate increase is very reasonable. The issue with the net patient revenue growth is primarily volume, which we actually can't really stop from happening. And I'm pleased that people want to come here and use our services. I think it's beneficial to the state of Vermont. It's beneficial to Mount Ascutney that if we're able to enhance our volume from outside this state, it's a benefit to everyone involved here in Vermont. I can't say the same for the person losing the business on the other side of the river, but it's an increase to provider tax, it's an increase for jobs. It has a multiplying effect over time, and I would hope that you guys would consider that in approving our budget. We're not generating new business. We're just taking care of whoever shows up and doing the best job we can. But we appreciate your consideration and look forward to a favorable response.
Well, thank you very much. And Mr. Brown, it's nice to meet you. And I think we will adjourn. Thank you. And we'll adjourn till 1 o'clock. Thanks.
Thank you all. Thank you all. Thank you.